Thank you all. I'll be just simplifying the whole talks what we had in the since morning, what we were listening. So we thought we just bring about a Pachychoroid algorithm. It might overtly look a little bit oversimplified, and of course, considering the lot of complexities and the dilemmas and the imaging questions that we are having, definitely it does look a bit oversimplified. But I think this basic understanding might be of great benefit to the clinicians to at least come to some conclusion as to what they're dealing with in the day-to-day clinical practice. So without much ado, let us just delve into it. The thick choroid on OCT is something we all come across. So if there is thick choroid as well as thick vessels is when you have to identify this in the beginning. So the next part of it will be to identify where the thick vessels are, whether they are deep dwelling inside the choroid or are they rich abutting the RPE. So this simple, you can see that this is a condition where you have an acute CSCR and you have the thick vessels which are deep down and they are not having any effect on the adjacent satellars or the choricapillary alterations. So this is an acute CSCR. On the other hand, you have the thick vessels which are much more closer to the RPE, causing a compression effect on the satellars and the choriocapillaries. And you can identify this as the pachyvessel-driven pachychoroid diseases. So now let us move on to, once you find out that there's a pachyvessel pachychoroid disease, what next? So identify whether there is any RP irregularity or not. So once you find that there are some RP irregularities or abnormality, and this is the only feature what you're seeing there, then probably what we're dealing with is pachychoroid pigment epitheliopathy. So now look further and see if they are seeing some kind of a neovascular component. As we were discussing now, presence of a double layer sign, or the presence of a thumb-like projections, or if you're seeing some hemorrhage, exudates, that should drive us to think whether we are dealing with a neovascular component. So an OCT angiography or better still an ICG angiography can throw light onto it, and we will be able to identify either a PCN or a PCV lesion. If this neovascularization component is ruled out and we are dealing only with RP irregularities and it is very, very subtle, few changes, as Dr. Vishma told, some small white dots there in the posterior segment, then we can be just having a pachydrusen. If these things are more extensive and you're seeing telltale signs of previous fluid or current fluid, then what we're dealing with is CSCR. So just if none of these features are there, neither RP irregularities, but only a pachyvessel and a pachychoroid, then it could be an uncomplicated pachychoroid disease. So we will just drill into a little bit of clinical scenarios. So if you look at the OCT there, you can see that it is a pachyvessel, pachychoroid. You can see the adjacent attenuation of the choriocapillaries and satellus layer, but you can see also a double layer sign. This is what was discussed, when to think about a neovascular component. So we have a high index of suspicion, and of course in this patient it's quite evident. We saw a thumb-like projection, and definitely an ICG showed the presence of a polyp and a BVN. And this is a chronic active CSCR because we do see the fluid on the temporal side there, and with the PCV-like lesion. And this is another patient who, again, has the typical features of a pachyvessel, pachychoroid, but you also see a double layer sign there. And when we went ahead and did an ICG here, you could see the clear, the BVN, the branching network over there. And this is a pachychoroid neovasculopathy in a patient with chronic inactive CSCR. So this algorithm can help us to identify the final condition what we are dealing with. Now, suppose you're not able to see the visible dilated choroidal vessels on OCT, then we go on to the right side of the algorithm, which is whether you are dealing with a thicker choroid, which is diffuse and more extensive, or you're dealing with a thick choroid, which is more focally present. And in these cases, again, so this is a diffuse thick choroid and a focal thick choroid, more localized thick choroid. So again, in this, again, we need to rule out the possibility of pseudochoroidal thickening or apparent choroidal thickening. I think that will be dealt with Dr. Ramesh in the next talk. And to identify this apparent or pseudochoroidal thickening, as we were mentioning that there are a lot of imaging parameters which take place, and thereby we might actually end up seeing an apparent choroidal thickening. This usually happens when there are pigmentary changes, and loss of pigment in the choroid can reduce the dampening effect of the light passing through, and thereby you might be actually seeing the choriocerebral junction so prominently that it might give you a false appearance of a thickened choroid. So once you have ruled out the possibility of a apparent thickening, then coming back to the diffuse thick choroid, you are now evaluating whether these patients have got any kind of a inflammatory condition, infiltrative conditions, or a congestive condition, or some kind of a genetic condition like the posterior microophthalmos or nanophthalmos. So if these things are not present, it can still have a diffuse thick choroid, depending on the hyperopic characteristics and the ethnicity of the population. So leaving this aside, so this is another patient where you can actually put in the algorithm. You see a thick choroid, but you don't see dilated choroidal vessels. It's a diffuse thick choroid with choroidal undulations. Again, when we did the FA for these patients, you could see the pinpoint leakages and profuse leakages in disc hyperfluorescence in late stages. This is a case of Harada's disease. So again, there's a patient who walked in, a young patient who walked in with headache and dizziness. Again, a diffuse thick choroid, few hard X-rays in the retina, and coexisting hypertensive retinopathy, and I think it's a hypertensive choroidopathy patient. So again, diffuse thickening of the choroid. So if we come back to the central part of the algorithm, we can see that if you have a focal thick choroid, what next? Again, this focal thick choroid is a little bit of a controversial condition. So if you see more amount of this focal thick choroid in the macular region or outside the macular region. So in the macular region, having ruled out the focal inflammatory conditions, the most common conditions which we come across as a focal thick choroid is usually the alteration in the sclera, which in turn causes the choroidal congestion. So coming to the dome-shaped maculopathy or the staphyloma-induced maculopathy, wherein you have an alteration in the sclera, and thereby there is a localized choroidal congestion giving rise to the fluid collection. And now moving on to the outside the macula. So suppose there's a focal thick choroid which is outside the macula, it is important for us to identify whether it is peripapillary or peripheral. The peripheral congestion of the choroid is usually is when we call it as PHCR. Again, this is highly controversial whether PHCR is a part of the pachychoroid disease and what exactly causes PHCR, whether it's exudative or a neovascular-driven condition. But definitely there is a consensus that peripheral congestion of the choroid, in fact, is responsible for the PHCR. If it is a peripapillary pachychoroid syndrome, we find that the congestion is more so in this, around the optic nerve, and thereby it is a slow effusion of the fluid into the choroid, into the retinal spaces, and thereby we see the effect of the peripapillary pachychoroid syndrome in the surrounding area around the optic nerve. So I think this algorithm, of course, as I mentioned before, I started with a disclaimer, it's oversimplified, but I think it gives you a good idea about starting off with whether there is a thick choroid and a thick vessel, and moving on to finding out whether it's a diffuse thickening or a focal thickening, and identification of these parameters can bring us to somewhere close to the diagnosis. Thank you.